Welcome back. It's time for Chapter 3 and lifting and moving your patients. This next class will be a lot of fun because we'll be lifting and moving people and learning how to use all the lifting equipment. The first thing you need to know when you're going to lift somebody is that you need to be able to know your limitations and then know the process of how to lift somebody to prevent injury to yourself and also to facilitate lifting and moving much more easy. So you've got to lift smart, not so much use all your muscles and work out and become real muscular, although being healthy does help. So consider the following before lifting any patient. First of all, the object you're going to lift, its weight, whether it would require additional help to lift. And if you know you're going to a large patient, and a lot of times we have repeat patients that are very large, then you know about how many people you'll need to lift safely and efficiently. Next thing is you need to know your limitations. How much can you lift? Are you a smart lifter? There's a lot of times that the tiniest little female that you would think could never lift anything, and she is the most efficient and best lifter of anybody. Communication. Communication is key. You need to make a plan, communicate it with your partner. Everybody needs to be on the same page. First of all, the rules for lifting. Position your feet properly. Use your legs. Never turn or twist. And then don't compensate when lifting with one hand. A good position to use when you lift is called the power lift. I want you to turn to page 54 and 55 where you're going to learn proper techniques for lifting and moving. Keep the weight as close as possible to your body. Holding a stretcher at arm's length away from you is not utilizing proper mechanics. You've got to pull that weight in and hold it against your belly and lock those arms. So make sure that you do that because this allows you to actually use your legs more rather than using your back. And another rule is to use a stair chair when carrying a patient on stairs whenever possible. This is the safest way to carry a patient up and down steps, is a stair chair. That's a picture of a stair chair. They have ones now that have little tracks on them that actually helps you to move the patient on like a little track. Okay, the power lift and the power grip. The power lift, it's named that because it's used by power weightlifters. And if you've ever watched a power weightlifter, when they're getting ready to lift, they squat. They kind of position themselves. They squat rather than bend at the waist. They keep the weight close to their body and sometimes even straddle it. But if you want to know how to prepare for a lift, just watch weightlifting someday on TV and you're going to see that their back is locked in, their arms, and take a look at what they use. There's another method called the power grip. Bring your hands in from underneath. Keep every part, as much of the palm of your hand touching the surface as possible and get a good grip. If you're going to try to grip from the top, if you've got a heavy object, it's going to easily slip from your fingers. So remember to use the power grip and the power lift. When you reach, keep your back in the locked position. Avoid twisting while reaching. And avoid reaching more than 20 inches in front of your body. And also avoid prolonged reaching when you've got something that's pretty strenuous going on. When pushing or pulling, It's always better to push rather than pull, if possible. Keep your back locked in. Keep the line of the pull through the center of your body, so don't have it like way up high trying to pull something or way down low trying to pull something. And then keep the weight as close to your body as you can. If the weight happens to be below your waist, then push or pull from a kneeling position to try to get that centered right in between, centered in your body. Avoid pushing or pulling overhead altogether. Keep your elbows bent and your arms close to your sides. Okay, some situations that you might get into is going to determine what type of move you would use to move the patient. There's three types of moves. There's emergency moves, there's urgent moves, and there's non-urgent moves. Now, emergency move is just like it says. The patient needs to be moved to a safe place, probably before you have time to even complete an assessment or to think about whether they have spinal injuries or anything else. This is a situation where you need to move them and you need to get them out of there quickly. The possible situations, there's three situations that might require you to use an emergency move. One is the scene might be hazardous. Some type of hazard might make it necessary for you to move the patient quickly to protect both you and the patient. Maybe there's uncontrolled traffic, or maybe there's a threat of fire, or the possibility of an explosion, or an electrical hazard, or a toxic gas, or radiation. But you want to get in there and you want to get them out of there before you worry about anything else. Another thing might be if the patient needs some type of life-threatening intervention that requires you to move them to get them to where you can work on them. You may have to move a patient to a flat, hard surface to provide CPR to them. And in that condition, you're going to do an emergency move. Or if you might have another patient that has something that they need have a life-threatening condition. Like there might be a patient at the scene that requires life-threatening care and you need to move another patient to access them. For instance, I had a little girl one time that was underneath her father actually in a car accident. The car had been overturned and we needed to just move the dad out and get him quickly out so that we could get to the little girl. So in that case, we did an emergency move. So the greatest danger to the patient in an emergency move is that the injury might be aggravated. But since the move has to be made immediately to protect the patient's life, you might not be able to worry about the spine or anything else injured. So if that's the case, when at all possible, you want to try to move the patient in the direction of the long axis of the spine. So the length of the spine whenever possible. The long axis is a line that runs down the center of the body from the top of the head and then along the spine. So try to move in that direction. For instance, an emergency move might be a clothes drag. And we'll practice these at class. So most of the drags are considered emergency moves. The incline drag, and if you notice, they're moving them along the axis of the spine. The firefighter's drag, and the blanket drag. There might be a one rescuer assist, and this would be somebody that might possibly be able to help you a little bit. So they'll be fairly alert and maybe be able to move on their own a little. A two rescuer assist. And the next type of move is an urgent move. Urgent moves are performed with thinking about spinal injury and precautions you would need to not aggravate it any further. So, an urgent move, type of urgent move that is a lot of times utilized in car accidents is considered to be rapid extrication, where we extricate them rapidly, but we still use spinal precautions. Okay. The required treatment can still be performed only if the patient is moved and the factors at the scene cause patient decline are situations when you would use urgent moves. Another way to move a patient urgently, which I just talked about a little bit, is rapid extrication. In rapid extrication, you move the patient onto a long spine board and get them out of there, although you have taken just a little bit of time to immobilize them and prevent further injury. So spinal immobilization or backboards are used if immediate threat to life and suspicion of spinal injury is the potential. Sometimes if the patient is lying down on their back, you can log roll them onto the side, or you place a spine board next to the body, log roll onto that board. If you're using some form of spinal mobilization, it's an urgent move. Move the patient on a long spine board, lift him onto the stretcher, secure him to the stretcher, and then load him into the ambulance. Rapid extrication is an urgent move. You can put them onto a short backboard or use what we call the KED, which we'll introduce you to in class before moving the patient. But a lot of times using the KED board is not necessarily an urgent move because it takes a little bit longer to use the vest type device. Non-urgent moves is when the patient is completely stable. There's no thoughts of immediately life-threatening conditions, so they're fairly stable. The patient can be assessed and treated and moved in a normal way, and you can take all required precautions not to aggravate existing conditions. Some patient carrying devices, stretcher or any other device designed to carry the patient safely to the ambulance or the hospital. We have wheeled stretchers, we have power stretchers, we have manual stretchers, and we have a bariatric stretchers. Bariatric stretchers are rated for at least 800 pounds. And yeah, we do have patients that are that big. Bariatric means a very large patient. One of the terminology that you need to be familiar with. So, bariatric is having to do with patients who are significantly overweight or obese. And here is a wheeled stretcher that you can take your patient to the ambulance with. It's so much easier to wheel patients than to have to carry them to a vehicle. This is the Furno power stretcher. It's a hydraulic type stretcher that goes up and down, so there's not a whole lot of lifting involved, and these help you to take it easy on your back and not wear your back out so quickly. When you're using stretchers, this is a bariatric stretcher, but when you use stretchers and when you move the patient, the safest level that you wheel the patient along is the level closest to the ground. If you're wheeling the stretcher in the elevated position, that raises the center of gravity and it's easy for the stretcher to tip over. So when you're wheeling your stretcher, lower it down just a little bit so that it's nice and straight and the center of gravity isn't upright. Because the patient a lot of times will be sitting upright anyway. and that's going to change the center of gravity. Don't wheel in the top position of the stretcher. Other patient carrying devices, we have stair chairs. These are very useful when you can't use a stretcher, and it's much easier to transport a patient in a sitting position down the stairs. This is recommended. It greatly reduces the length of the patient device, and it also allows you to maneuver around corners and through narrow spaces. So it's still the ease of rolling, but it's much easier and safer to use a stair chair in the stairways. Spinal board. There's short spine boards. This is when you're removing patients from vehicles and you suspect they might have neck or spine injury. Or there's a long board, and that's generally for full body immobilization. And here's a stair chair. This is a fairly useful device, which we will be practicing with. And here is a short spine board. This is not necessarily the type we use anymore, but they can be used. You can secure the patient that's been in a car accident, so to speak, in a short spine board, and then you transfer them to a longer spine board as you remove them. And here's your long spine boards. Some other types of stretchers. There's portable stretchers, which usually are folding type stretchers that can be used in mass casualty situations. There's scoop stretchers, which come apart in the middle and kind of scoop your patients up when you don't want to have to roll them onto a board. You have a basket stretcher or a Stokes stretcher. You can use that to move a patient from one level to another, or you can move them over rough terrain or lift them from lower places to higher places. There's something called a flexible stretcher, or a specific type of device that could be used as a flexible stretcher is a Reeve stretcher. It's made of canvas or some other rubberized flexible material. Sometimes they have wooden slats sewn into pockets and 3 carrying handles on each side, but it's very flexible and you can use it in restricted areas or narrow air hallways. And then there's the vacuum mattress, which we use quite frequently to fully mobilize people, but it keeps them more comfortable than having them lying on a backboard. You can see a picture of that at the bottom of page 67. These kind of come up and they secure around the patient. Fairly comfortable, especially for the elderly who have broken hips, and sometimes they might be on that device for 3 or 4 hours, and so there's there's not much risk of developing skin sores from it. It's so comfortable. And then we have, this is a vest type extrication device. This is similar to the short backboard we've seen. And this is what we call a KED board, Kendrick Extrication Device, KED. This is for removing people out of car accidents, and you can move them and keep them immobilized. It comes up and around their top torso or their torso, and you can get them out of a vehicle without damaging their spine. This takes a little bit of time to put on, and that's why it's useful in a non-urgent move. This is a scoop stretcher. Comes apart in the middle. You can see that it's got a way that it breaks apart at each end, and that's how you would scoop a patient up if you didn't want them to log roll or to be moved very much. And here's your basket stretcher or your Stokes basket. This is a folding flexible stretcher. Very useful when you've got a mass casualty situation and there's not very many stretchers, wheel stretchers around, or they're being used by the ambulances. So this is a useful way to move patients. And then a vacuum mattress. Very comfortable for the patient. So how do you know what type of device you're going to carry your patient with? Well, a lot of um, positioning depends on their medical condition and what device is best designed to help use that condition to move them. A patient with suspected spine injury might need their head, neck, and spine immobilized. And so the first thing you would do is you'd perform manual stabilization. So you just hold their head. And then you put a C-collar on, and then you maintain that manual stabilization until a backboard is placed. So if you're going to immobilize somebody, it starts with the head, and whoever is going to hold the head pretty much is going to be holding that head until the patient is securely positioned to the backboard. If they don't have a spinal injury, you can use the extremity lift, and you'll see some pictures of that in the book as you lift a patient either from their legs and their arms, such as in this picture, you could do an extremity carry. This is definitely, these types of moves are for patients without suspected spinal injury. So a direct ground lift, lifting from the ground to the stretcher, or if they're laying flat like that, you can just lift them, two people on the same side, and kind of curl your arms up with the patient in them and lift them to the stretcher. You notice they're using proper lifting techniques there. And they have lowered that stretcher so that they don't have to lift very far. Just think if that stretcher was up high and they'd have to lift the patient and then try to stand up with them and put them on the bed. Try to lift smart. A patient with no suspected spinal injury, you can use a draw sheet method or direct carry method. So moving from one stretcher to another. This is used a lot in the hospital. You take the sheet and you roll it up. Roll it up as close to the patient's body as you can get. You can see they've got it rolled up, but they're not very close to the patient's body. That leaves a lot of play in that room. Get up there, roll it right up to their body, and then slide them over. You have more control over it then. And then they place them onto their stretcher. The recovery position. The recovery position is on their side. This is for a patient that might possibly have might be prone to vomit. So unresponsive patients with no suspected spine injury should be placed in the recovery position. The patient should be on his side to aid drainage from his mouth, and if he vomits, it won't go anywhere except for out onto the stretcher. This will help prevent vomit to go into his lungs. If the patient is in shock, and we're going to talk about the signs and symptoms of shock, but if you think he's in shock, then they should be placed in the supine position. Supine means laying flat on their back. You don't put the head lower than the body. You don't raise the legs. That has been shown to be not very effective. But if you believe they're in shock, put them in the supine position, and that way they're going to have maximum blood flow throughout their body. So when you get to the hospital, you're going to move the patient from the ambulance stretcher to the hospital stretcher. Modified draw sheet method as we move the patient from one stretcher to another. Saw a picture similar just in the past few slides. And here they are. Going to position the ambulance cot next to the stretcher. Make sure you get the beds the same height. And then grasp the sheets. Grab the sheet as close to the patient's body as you can. And then slide them over. Usually it's on the count of 3. And the person at the head is always the one we consider the person that controls the move. So they count 1, 2, 3. Communication is key to this. Everybody needs to be looking at each other and focused on what they're going to do. And then make sure that the patient is centered on the stretcher and the rails are up before you turn them over to the emergency department.
Properly moving a patient from where they were found and then to the ambulance needs to be accomplished on most EMS calls. In most cases, this is done slowly and carefully. In some serious patients, the lifts may need to be done very quickly to move the patient out of harm's way. In all situations, it is necessary for the first responder to understand which would be the best means of lifting the patient, how to use the device chosen to remove the patient to the ambulance, and how to use good body mechanics to minimize the potential injury to themselves or their partners. In this video, we will discuss the type of lifts and moves, as well as tips to help you safely lift and move your patient. First, it is essential that the first responder understand body mechanics. Body mechanics is the proper use of the body to prevent injury and to facilitate lifting and moving of the patient. Prior to lifting any object, consider the following: the patient's weight. Will additional assistance be required? What are the physical lifting abilities of you and your partner? Plan how you will accomplish the lift and communicate it. Another important aspect of body mechanics involves following a few simple rules when lifting. Position your feet on a firm surface and shoulder width apart. Use your legs, not your back, to lift. Do not lean over and compensate when lifting with only one hand. Keep the weight as close to your body as possible. Rather than carrying a stretcher or reeves downstairs, use a stair chair. First responders can be prone to injury when they are placed in a position where they are reaching, pushing, or pulling. To prevent injury when reaching, the first responder should keep your back in a locked-in position. Avoid twisting while reaching. Avoid reaching more than 20 inches in front of you. Avoid a prolonged reach when a strenuous effort is necessary. When pushing or pulling, the first responder should try to push rather than pull when practical. Keep your back in a locked-in position. Keep the line of the pull through the center of your body by bending your knees. Keep the weight close to your body. Avoid pushing or pulling overhead. Keep your elbows bent and arms close to your sides. To prevent injury when lifting patients, the first responder should try to use the power lift and the power grip. The power lift involves squatting rather than bending at the waist and keeping the weight as close to you as possible. The power grip involves using as much of the area surface of your hands and palms as possible. All fingers should be bent at the same angle. The palms should be up underneath the object you are lifting, and the two hands should be at least 10 inches apart. There are 3 classifications of moves: emergency moves, urgent moves, non-urgent moves. An emergency move is done as fast as possible with little regard for spinal integrity. An example would be a patient where the car is on fire and the patient needs to be immediately removed. An urgent move needs to happen very quickly, but there is time to be cautious and not aggravate a potential spine injury. An example would be the rapid extrication technique used for the critical trauma patient found in a seated position in an automobile. A non-urgent move is used for the majority of moves, and it is used for patients when there is no immediate threat to life or limb. Usually, the patient is assessed and managed prior to the movement, as is the case of assisting a cardiac patient with chest pains onto the stretcher. Let's review the steps for a number of lifts used in the field. A one rescuer assist can be used to move the patient into a safer area. Place the patient's arm around your neck. Grasp the patient's hand in your hand. Place your other arm around your patient's waist. Then help the patient walk to safety, communicating with him or her about obstacles or uneven terrain. The two rescuer assist is done in the following manner. Each first responder stands at one side of the patient. Each places a patient's arm around his or her shoulder and grips the patient's hand. And then, both the first responders help the patient walk to safety. The direct ground lift is often used to move a patient to the stretcher. To accomplish this, the following steps are taken. Set the stretcher in the lowest position and place it opposite the patient. Both the first responders get in position along one side of the patient. First responder number 1 is at the head end, and first responder number 2 is at the foot end. First responder number 1 will cradle the patient's head and neck by sliding one arm under the neck to grasp the shoulder. The other arm should be placed under the patient's lower back. First responder number 2 will now slide one arm under the patient's knees and the other under the patient's back, above the buttocks. If there is a third rescuer available, have them place both arms under the patient's waist, while first responders 1 and 2 slide their arms up to the mid-back or down to the buttocks. On a signal, the crew lifts the patient to their knees, stands and carries the patient to the stretcher, drop to one knee, and roll forward to place the patient onto the mattress. There are a number of emergency moves that can be used by a single first responder to quickly move a non-spinal injured patient. To do the firefighter's drag, take the following steps. Place the patient in the supine position. Tie the patient's hands together with something that will not cut into the skin. Straddle the patient using his or her head. Crouch and pass your head through the patient's trussed arms and then raise your body to raise the patient's head, neck, and upper trunk. Crawl on your hands and knees, dragging the patient and keeping the patient's head low to the ground. A blanket can be used for a blanket drag. Gather half of the blanket up against the patient's side. Roll the patient towards your knees. Gently roll the patient onto the blanket. Roll up the blanket by the patient's head, neck, and shoulders, and drag this rolled material, keeping the patient's head as low to the ground as possible. The last emergency lift we will review is the firefighter's carry. Place your toes against the patient's toes and pull the patient towards you. Bend at the waist and flex your knees. Duck down and pull the patient across your shoulder, keeping hold of one of their wrists. Use your free arm to reach between the patient's legs and grasp their thigh. Let the weight of the patient fall onto your shoulders. Next, stand up, transferring your grip on the patient's thigh to their wrist.
So, in review, the process of lifting and moving patients is a task that you need to plan, you need to have proper equipment, and pay careful attention to your body mechanics to prevent injury to you and to your patient. The most important rule in lifting is to lift with your legs, not your back. Keep your feet shoulder width apart and keep your knees bent Rules for lifting are for patients as well as for equipment. Use the power lift. Emergency moves are those that may aggravate spine injuries and therefore are reserved for only life-threatening situations. Urgent moves are used when the patient needs to be moved quickly, but there's time to provide a quick, temporary consideration toward preventing or aggravating a potential spine injury. Non-urgent moves are normal ways of moving a patient to a stretcher after you've done a complete on-scene assessment and you've completed any spinal stabilization or immobilization. Pay close attention to positioning the patient for transport, and you should take into account the patient's comfort, medical needs, and safety. And remember the importance of correct lifting and moving techniques on every call. Protect your patient and you protect yourself from injury to maintain a long and positive EMS experience. I would like you to turn to page 69 in your book and look at the critical decision-making box at the very top. And I want you to look at the questions 1, 2, 3, and 4 and choose a patient carrying device for these questions. And then look in the back. You'll find the answers in the very back under Chapter 3, Critical Decision Making. And figure out what you would use to transport these patients. Number 1, a patient complaining of severe respiratory distress who is in an upstairs back bedroom. Someone in respiratory distress needs to be transported in the position of comfort, but they're upstairs, and what's the safest way to move somebody upstairs? By a stair chair. And that also keeps them in the position that they might be most comfortable in, which is sitting up. Number 2, a patient thrown from an ATV several hundred yards into the wood. That person has the potential for spinal injury and would need to be immobilized. 3, a patient who fell down several stairs from the back deck to the concrete landing who complains of neck and back pain. Once again, they have the potential for spinal damage and would need to be fully immobilized on a backboard. And number 4, an unresponsive medical patient found down a narrow hallway on the first floor. Probably a stretcher if you can get it down the narrow hallway. You wouldn't put him on a stair chair simply because he's unresponsive, and you shouldn't transport an unresponsive patient upright on a stair chair. They can't maintain their airway that way. You could also use a drag to drag them down the hallway and put them on the stretcher. Review that box and then look in the back for answers. Remember, proper lifting technique is important. It helps keep you well and your back strong. Biomechanics and rules of lifting help prevent injuries associated with lifting. Many different patient carrying devices exist. Choose the correct device based on particular patient and the needs of the particular move. Use proper technique to move patients on patient carrying devices and position them for transport based upon their condition. So remember to think about these questions and consider, why are body mechanics so important when lifting and moving patients? It helps you to maximize the move and to maximize your abilities. Why is using an appropriate patient carrying device an important consideration? The devices can be very helpful for you in making the move easy and smooth. When would an emergency move be necessary? This is when there's life-threatening conditions exist that you need to move the patient quickly and you don't have time to consider spinal precautions. In what ways can proper positioning help a patient's condition? Well, if you place the patient on the left side or on their side in the recovery position, that can help if they need to vomit, that they will not aspirate any vomit into their lungs. So you arrive at a vehicle crash. You find an elderly driver slumped over the vehicle. When you examine, you determine the patient is in respiratory arrest, but not trapped in the vehicle. Which move would be appropriate for this patient? So this person is unresponsive. They're slumped over the wheel and they are not breathing. You can get them out of the vehicle because they're not trapped, and so you don't need the jaws of life or anything. This patient has a life-threatening condition. If they're not breathing, they're going to die, and they're going to die quickly. Do you have time to consider spinal immobilization on this patient? Not necessarily. They're in respiratory arrest. So this person would be moved using an emergency move.